So thank you, Carrie.
Thanks. I threw up there a couple of little personal things. I live in Seward. What did I say? Oh, I'm married. I have 4 kids. My husband and I are foster parents. We lived at Boys Town for a little while. During my tenure there, I started my career at Boys Town, so I spent the first, give or take, about 10 years there. So now Kirk and I are both foster parents. I put up there that I am an introvert because I think that that's sometimes like when we're starting to really understand people and when we're people watchers and we like to kind of think about what our kids are like, we might make assumptions about what we think they're like or what seems to be the most visible characteristics. And so you would think if I'm standing up here, and honestly, there could be 20 of you, there could be 200 of you. We were really optimistic this evening. We were like, yes, we're gonna feel, no. So, but I'm not. I mean, I'm not the person who wants to like mingle through a party. If there was a social event and there was 100 people where I'm not up here with a microphone, I'm like, yeah, no, I'm good. I'm standing at the, standing at the bar. Can you edit that out? Can you edit that? I'm standing at the bar, holding it up with a drink in my hand. No, I mean, so again, we have to take kind of what we think we know about people and just be a little bit more thoughtful about how they present and maybe some of those assumptions that we make. Things that I love to do would be introverted types of things. I work out, I read, and I watch movies. I can do all of those things alone. And I love what I do. I've been in this field for, like I said, 24 years now, and absolutely am 100% passionate about what I do. When people ask me to talk about something about me that isn't related to what I do, I struggle. I really struggle. When I say I like to read, I'm the nerd sitting there reading the books about this kind of stuff. I mean, that's my spare time. So those are the kinds of books I enjoy researching. I'm a perpetual student, always wanting to know more. In terms of my practice, I threw this up there because, like I said, I am really invested in what I do, and I take kids really seriously, and I really like them a lot. And so I want to help give them a voice. I want to help give them as accurate and authentic a voice as I can, and that's from little itty bitties all the way up through adolescence. And so really trying to connect with them and understand them really helps to make that, doable or workable. If kids don't think you get them, then obviously it's not really a great connection. So those are the different certifications or additional training that I have had in my clinical or professional practice. So tonight, when I say demystifying mental health, I want to talk about it as a reality that we all have mental health. I don't mean that we all have a clinical diagnosis. I mean we have something called mental wellness. We have something called mental health. And so if we have physical health, it's not really a thing or a stigma to talk about, or if there's a medical that we need to go get, oh, I might have asthma, or maybe I ended up, I got diagnosed with diabetes. I mean, these are serious conditions that we have to treat, but we're not nearly as concerned about talking about them as when we say this mental health. We automatically just have it connected with something very negative. So we want to look at social emotional development and then the whole big realm of mental behavioral health. Really differentiating between what's typical and what's diagnosable and how that even comes to be. And then healthy next steps if you think maybe you need to seek out some professional guidance. I did put blank note cards over there at the table outside and along with my contact card. So a couple different options if you have questions. If you don't want to raise your hand and ask a question, but you'd rather write the question down, I'm happy to collect note cards kind of towards the end and go through them and just answer them. So you can, leave them anonymous, obviously. If you want, I can just email you an answer. If you want to put your email on there and you don't want me to answer the question publicly like this, I can just throw you an email answer. But sometimes if you're okay with it, if the note cards come in and either we don't have time, or it's a question that a lot of people ask, as long as it's anonymous, I might rephrase it to make it super generic, and I'll put it on my Facebook page with a response. And so if you want to kind of keep in touch, I'll put resources on my Facebook page and kind of links to say, hey, here's what I recommend, here's where you can connect. And so my email, my cell phone, everything's on that card. It's like I'm an open book. So get a hold of me anyway, anytime, anyhow. So it starts with infant mental health, and when I say infant mental health, a lot of times people who are really not familiar with the field question what we mean by infant mental health. So when we look at the true accepted definition, there's a World Association of Infant Mental Health, just FYI, it's a real thing. There's a Nebraska Association of Infant Mental Health as well. Like, what? Seriously? Yeah, because really what is infant mental health? Well, it's kind of fancied up the term of social emotional development, truly. And we'll talk about social emotional development a lot, and sometimes you'll even see it as an acronym, SEL, social emotional learning. But really, what is infant mental health? It's the developing capacity of the child from birth to 5. Infant mental health also, FYI, sometimes has a range, birth to 5, birth to 8, and I've even heard it birth to 10. So right now in the state of Nebraska, the majority of us who are operating in the world of infant mental health, we accept it birth to 8, which means any services that we're providing for kiddos up through grade 3. We all bucket that as early childhood or infant mental health. But it's the developing capacity of children to be able to do some socially, emotionally based things. Number 1, I want babies to experience emotions. Fair. I want babies to have emotions. I want babies to be able to express emotions. Flat, affected babies worry me. Babies who don't have emotion, that's concerning. So I want babies to have emotions. I want babies to express emotions. And then eventually, through our guidance and support, I'm going to want babies to get to the point where they can regulate. I like the word regulate better than control. Again, it's a connotation thing. It's how people perceive it. Control to me feels like stifling or stopping or jarring or boxing or whatever, halting. Regulate sounds nicer. So it's a softer way of saying I want kids to be able to have emotional experiences and be able to express emotions freely, but in a healthy way, which means they can manage it. They can regulate it. I don't expect babies to not ever cry, and I don't expect toddlers to not ever cry. We just want them to be able to have that experience where they do cry and then being able to come out of it healthy. That all happens within the context of a relationship. Little people need an adult to help them do that. Hopefully they grow in that ability as they get bigger. I want little ones to be able to form close and secure interpersonal relationships. I want kids to want a secure adult. I want them to reach for you if you're their attachment figure. I want them to be sad when I pull them away from you. Not aggressively, just if you're handing me your child. I want them to lean towards you and not really want me because you're their safety, you're their security. If they'll kind of go to anyone, if there's no distress upon leaving their caregiver, depending on the age, those are things that we kind of look at and just want to explore more. And I want kids to be able to explore the environment. So if that's my definition of infant mental health, it truly is social emotional learning. So when we use them, we kind of can use them interchangeably. Now, birth to 5, because it all starts down at the very beginning. Your mental health doesn't magically appear one day when you're 12. And in fact, true story, we have more awareness and more education coming all the time. And we have actual brain imaging and brain scans. And so we have like concrete, like hard science proof of all of this now, which is just so lovely. Kind of what we've known for years, we can actually connect and prove with pictures and videos and stuff. Nonetheless, there used to be court reports when like maybe there was some struggles happening in a home and maybe something happened in the home that necessitated maybe children being removed from a home or somebody else coming into a home and kind of ensuring safety. Court reports would literally, and I think they might still in some counties, not here in Lancaster anymore, they would literally say, child is under the age of 5, child does not need any mental health services. Like the preconceived notion was 100% children under the age of 5 magically had no concept of what was happening around them. They had no ability to be scared by domestic violence or frightened by insecure, parents coming in and out or instability, that's the word I wanted, instability. Like I cry and you help me one day and the next day you cry and eventually I cry myself out and then you're not there, so this kind of instability. Babies are 1,000 times aware. And it's the first 3 years that all of this is getting wired. It's the first 3 years that this is created and formulated, and this is really that foundation to the rest of that brain development. So these first 5 years here, we're saying all in the context of family, community, and cultural expectations. That's all happening, not like, hey, here's a baby. There's no such thing as, here's a baby. There's a baby and whoever else that baby is with. So if we look at that, when we look at mental health, we're looking at these 3 developmental domains. Again, there's physical. We don't think twice about talking about physical expectations, either fine motor, they can hold a pencil, Gross motor, they can hop on one foot. Okay, physical development, they're tall for their age, they're short for their age. Any of those things. Growth chart, oh, they're 90%, they're 10%. That's all stuff that anybody is perfectly comfortable sharing and talking about. Then there's the cognitive developmental domain. That's the part of your brain that's like the intellectual part, right? The problem solving. Have you ever gone on YouTube and found those videos of babies that are like 18, 24 months old, and they're literally like climbing over like door frames and baby gates and throwing, have you, anybody, wait, okay, you nodded, thank you. Those videos are genius, I should pull one up. They have all these YouTube videos of just the amazing cognitive capacities of little tiny people. There's one video, I swear the baby's probably maybe 9, 10 months old, honestly, crawling, not walking yet. Okay, maybe the little guy was walking. Okay, 9 to 12 tops. The baby's on a bed. He literally tosses pillows down to the floor of the bed and then falls off the bed onto the pillows to get himself off the bed. Dude, genius stuff right there. That's cognitive capacity. But then there's social emotional development. So when we have a child, oftentimes we run into the problem, the mistake, and we all do this because we're humans and we just take face value. We take the perception and we start making connections and assumptions. We might have a child who physically appears to be 12. Physically is even large for 12. Maybe he looks more like he's 16 or 18. And maybe cognitively that kid is smart. So maybe he's in some advanced classes. So we make assumptions that if physically that child is well-developed and cognitively that child is well-developed, we make the assumption that socially and emotionally they should also be well-developed and mature. But I've met plenty of 12-year-olds who socially and emotionally, 8, right? A little bit closer to 8, maybe, 6 on some days. And so we have to keep in mind, that's the part that we don't see as much or as readily. So when they they melt down emotionally, they can't problem solve, they have poor peer relationships. I would say those are some social emotional delays. Not that we shouldn't be, we should just intervene, not like, oh no, there's something wrong with him. Well, you know what, if he wasn't doing everything he needed physically, we would address it. If he's not doing everything he needs to cognitively, we would address it. If the child isn't doing everything he needs to do socially and emotionally, we should address it as neutrally as we address a difficulty or a delay in any other domain, not have it be something special or different. Why does it get so much notice? Why do we notice it and call it different, weird, do we don't talk about it? Because it's the most disruptive. It's the most disruptive. It causes difficulties in relationships. When you emotionally melt down, it causes a difficulty in the relationship with the adult that you're melting down with. If you have poor peer relationships, it affects your relationships with your classmates. It affects your ability to be able to interact with your teacher. It's the most disruptive. Not being able to maybe complete algebra successfully isn't particularly disruptive. We just get you supports and help until you start melting down and becoming defiant and yelling and swearing and throwing chairs. Social emotional. Now we don't have an ability to be able to withstand that kind of pressure, so we start acting out, and we act out socially and emotionally. That's the same thing as not being able to be successful at algebra. Okay, age-appropriate behaviors. What is developmentally appropriate? I don't know anymore. I honest to goodness don't. Seriously. I can't tell you for certain, look for these markers. For certain, if your child is doing this at this age. It's such a range. It depends on your kid's temperament. It depends on the gender, your environment, your expectations, cultural expectations, social expectations, what's happening within your family. All of these things matter. And so really, what is developmentally appropriate? There are red flags. You can Google it. You can find all these printouts about what is developmentally appropriate, what is an age. I had one mom who was struggling when she was talking about her kids. So, long story, I'll try to make it not long, but it's going to be long. So there's a mom, she was involved, a lot of the work I do is with the court systems and with families that are struggling. So I would say that's honestly about 75% of the work that I do is usually at-risk kids and families. And then maybe about 25% of the caseload that I had and the work that I've done is everyday, more typical family structure, and just seeing some mental health concerns where they would come in for some support or guidance, etc. So forgive me that a lot of my examples might seem a bit extreme. Of course, if they're coming to see me, you're going to assume that most of the examples I'm going to talk about are probably more on the extreme side, right? So mom and dad had been involved in some substance use, and they had lost children in their home, custody of their kids for a while, so kids were displaced for a while. Mom and dad ended up going through the court system and got clean and got back on track, and the kids returned home. And mom was struggling with some behaviors of her child, and she was expressing how the whole clean room thing, right? That's a big thing for a lot of us moms. Clean room, clean room, clean room, pick up your toys, pick up your mess, put your laundry away. And so when she was talking about strategies for helping to get her kid, to kind of keep the room clean and whatnot, I had to pause and say, oh, I should really ask, how old is this kid? Because in my brain, the way she was talking, I thought we were talking about a teenager. Kid was 9. So I thought, oh, okay, developmentally appropriate. Let's pull back a second. What really are the expectations we should be having for a 9-year-old as compared to what we should be having for a 16-year-old, right? So I suppose there are some awesome markers that we should be aware of, but I can't list them all for you right now. So that would definitely be resources to kind of reach out for and say, okay, am I on the right track? Are we looking at something? The kicker is obviously finding a balance within your home and the success of your family and the success of your child. What's the balance? Okay, mental behavioral health, emotional, psychological, and social well-being affects how we think, feel, and act. In cognitive behavioral therapy, there's a triangle, and we have our thoughts, and we have our feelings, and we have our actions or our behaviors, and they all intersect with one another. So we'll say, how I think impacts how I feel, right? If I'm thinking negative thoughts, I'm going to be feeling less happy. And if I'm thinking negative thoughts and feeling less happy, I'm going to be acting or behaving in a manner that would be more sullen. Or we can start with feelings. I'm feeling kind of depressed, and because I'm feeling kind of down and sad, I start having negative, pessimistic thoughts. Things never go my way. And then by default, it might impact my actions. I might engage in a behavior that ends up triggering some feelings. I'm driving and I get pulled over, I might trigger some feelings of frustration or hostility at the person who pulled me over, hostility or anger at myself for being pulled over, and that might affect how I'm thinking. I can't believe they pegged me, I can't believe. So it's all intersected. They all kind of go together and connect. So your emotional, psychological, and social well-being affect how you think, feel, and act. It determines how we handle stress, relate to others, and make choices. Big, huge, giant social emotional bubble. Mental health is important at every stage of life, from itty-bitty babies, prenatal, honestly, it's starting there, prenatal, all the way through the end of life. So why could somebody have a diagnosable mental health struggle? I don't know, just something new. Why would somebody end up with one? Okay, how come I have clinical depression? Why am I diagnosed with social anxiety? Why do I have obsessive compulsive disorder? Part of it is just biological factors, such as genes or brain chemistry. Nobody woke up in the morning and said, dude, give me a dose of ADHD. Totally looking forward to that. I would love to be able to walk around with ADHD all day, every day. They don't choose it. People don't choose it. So there could just be a biological factor. Genes, brain chemistry, period. Family history of mental health problems. So mental health, there are mental health struggles like depression, anxiety, ADHD that have a higher heritability. I think that's a word. Maybe I just made it up. They have a higher rate of showing that it follows in family tracks. It doesn't mean automatically. It doesn't mean absolutely if dad had ADHD, the kids are going to have ADHD. It just means the prevalence is higher within that genetic makeup. So there is a family history component. My grandfather, my maternal grandfather, was diagnosed with depression and was on antidepressants regularly through his adulthood. My uncle, his son, is diagnosed with clinical depression and is on medication. My mom thought she escaped it. So this would be her father and her brother. So my mom thought, dude, I got the optimistic, I'm not gonna have depression gene, yay me. And then she got old enough and life circumstances have changed. And she was like, oh, oops, it might be hitting. And so there are just some patterns and awareness that we have a family history of mental health problems. There are some biological factors and some chemistry abnormalities in your brain. It doesn't mean that, again, it's not choice. My mom's not thinking, dude, I really hope depression hits one of these days because I'm feeling kind of left out. My dad and my brother had it, poor me. So it's just something that happens that we have to be aware of. And then life experiences. Why does my mom feel like she's getting on that track of depression? She lives alone. Her life is more isolated than ever. Her kids have kids, and we're all living busy lives. So there are some social factors that maybe are triggering a predisposition. It's the same way with maybe like a substance use. You could have a predisposition where you are more likely to have an addictive type behavior, and so you just have to be more cognizant and more aware of that. Or life experiences such as serious trauma or abuse can absolutely cause mental health. One of the primary mental health diagnoses that we would talk about is PTSD. That absolutely would be caused by life experiences such as trauma or abuse. Now we also have to look at it and say, I have 100, and everybody talks about war veterans, so I'm going to go there first and then I'm going to go somewhere else second. Everybody talks about war veterans. I can have 100 soldiers go into the exact same situation, and give or take how many walk out with PTSD? 20. Give or take 20. Why? Why not all 100? Biological factors such as genes and brain chemistry, family history of mental health problems, resilience, temperament, all those things. All of those things go in. How come you walk out and the other ones don't walk out? Roll the dice, honestly. It's how your brain got put together. It's the lottery. I don't know. I mean, that sounds ridiculous and kind of flippant, but it's true. Now, when we talk about life experiences such as trauma, we're going to talk about other kinds of trauma when we talk about that issue in relationship to kids. So when I have a kid who I think is depressed, I have a child who seems like she has anxiety, I have a kid that everybody says has ADHD, but I've never really had it checked out before, when does it become clinical? Well, here's the fun part of my profession. There's no blood test. We're getting better at some brain imaging, and in fact, I think possibly Boys Town in Omaha might have some brain scanning machinery and capacities or capabilities to be able to do some actual brain scan tests to identify depression. Very cool. So we're getting there to be able to say, hey, we did a whatever kind of a, I'm not a scientist or an MD, so MRI, something. We did something where we looked at your brain, and this brain shows that it has depression, this brain doesn't. So we do have that technology, not readily available at all. So here's the scary part. I have a mom bring in her child, and I'm assessing the child, and I see certain factors. I go through all of my clinical training, I do all of my assessments, I do all of my interviews. I'm a little over the top, so I see this kid in multiple environments because I'm crazy like that. So I want to see the kid at daycare, I want to see the kid in my office, I want to see the kid at home with mom and dad. Because again, there's no such thing as just a kid, so I want to see the kid. So I'm doing my assessment and I'm getting a look at what I think is going on, and here's my diagnosis based on all these clinical factors and all these assessments and all these observations. True story. That little boy had 3 different diagnoses from 3 different providers. So when does it become clinical? I don't know. There's a fun answer for you. It's hard. It's really hard because there's not a blood test. There was one little guy, he's 8, that mom and dad brought him in. They knew something was going on. They were twin boys. They were both 8. One really presented as ADHD stronger than the other one, but they were both defiant, off the charts. So we started kind of nitpicking it through. What's going on? What's going on? What's going on? What's going on? And so sometimes the diagnosis isn't just as easy as a 15-minute doctor appointment with a pediatrician or a psychiatrist who spends 15 minutes and then gives you some medication. Sorry, I'm really harsh on my own profession. So it becomes difficult to really, truly understand the human being and try and come up with an appropriate diagnosis so that we can treat the child well, not just treat the child. So when we look at the behavior up here, oftentimes we see something like defiance. They're argumentative, they're moody, they don't make good decisions, I don't like the friends they're hanging out with. They're constantly, did I say argumentative? They're constantly arguing. What else? What else dictates middle school kids these days, right? You could be describing every day average Joe Schmo middle school kid. They don't want to pick up the room. Shocker. They don't really want to do their homework. Wow. They're always on their phone or tablet or device. Yeah, exactly. They're moody. They're argumentative. They don't want to talk to me. Yep, yep, and yep. Okay. So you could just have a kid. That's a kid. Or you could have more. So you do really have to know your kid. Now here's the struggle. I might think that I know what that is. Not me, you. You might think you know what that is, or you might have other people telling you they think that they know what that is. Hey, he's ADHD. Hey, she's depressed. Hey, it's whatever. Because they have their own preconceived notions, their own opinions, their own thoughts, their own perceptions. Great, 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 great. Here's the struggle. I'm going to take a challenging behavior of an 8-year-old, like this little boy who was a twin that mom and dad brought in. Defiant, 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 defiant. Oh my Lord, argumentative, defiant. So I went to his school and I hung out and watched him at school before he ever met me. So talked to mom and dad first, got the history, found out all the stuff without him being there, which is very difficult in our profession. Side note, very difficult in our profession because a lot of times a doctor won't see your kid without you, but I want to talk to you, I don't want to talk to your kid first, right? So that becomes really challenging because I don't want that 8-year-old to sit in there for that first 90-minute meeting while you say all the crap that they're doing. That's awful. No 9-year-old should hear that. No 8-year-old should hear that. Absolutely not. So I want all that stuff that you can be frank and honest and transparent with me and tell me all the stuff you need to tell me without that child hearing it. Then I went to the school and hung out and watched the kid where he didn't know who I was and he didn't know that I was watching him. So I hung out there for about 90 minutes. I probably would have been depressed if I was that kid and had to live in that kid's shoes for a day because in 90 minutes, you know, there was a lot of social isolation. There was a lot of like, stop it. I mean, let's just pretend his name is, what should we name him? Matt. Matt, stop it. Stop it, Matt. Matt, stop it. Stop it, Matt. I heard his peers say that to him constantly. I should have tally marked it. He constantly tried to get involved with his peers, so his social skills were off. And he was bumping into them and being obnoxious because he didn't know what else to do, but it got attention. It got a lot of kids saying, Matt, stop it, Matt. And then the only kid to ever get called out, I saw him at music, I saw him at PE, and I saw him in his regular classroom. And he was the only one to get socially called out in the entire room. PE teacher called him out through the whole gym. Matt, knock it off, blah, blah, blah. And then we get back into his regular classroom and the regular teacher calls him out. Matt, knock it off, blah, blah, blah. And I thought, okay, in 90 minutes, dude, I'm a little bit depressed being this kid. And so I can only begin to imagine what's going on with him. So we see the challenging behavior and we automatically jump to things like, oh, he's ODD, he's oppositional defiant disorder. Because he's argumentative and he's difficult with adults, right? So we're just going to label him ODD because it's the most obvious. It could be trauma. That kid could have trauma in his history and it presents as defiance and anger. That kid could have an insecure attachment. Now that's not an official diagnosis. We don't actually diagnose insecure attachment. They call it something else and that usually takes a lot to get to that diagnosis, but there could be an underlying attachment issue. Kid could have social anxiety. He could have social anxiety and he's working so hard all day to try and keep his social anxiety under wraps that he lets it loose when he's not social anymore, which is at home, right? Which is in the confines of my own house, so now I can melt down and be all the, like I'm so exhausted from keeping it together all day socially, because it was really, if anybody has anxiety, you know how difficult it is to contain that, so that you let it go, you become very argumentative, and nobody gets me, and they don't understand, and yada, yada, yada. Kid could have depression. 8-year-olds, 9-year-olds, 12-year-olds, yep, it happens. Kids can get diagnosed with depression, and it looks completely different than an adult with depression. Now, almost all the depression checklists for kids still kind of show things like, is your child sullen? Has your child lost interest in everyday normal activities? So I caution on just following that simplistic of a checklist to make assumptions of depression. No, they are really argumentative and angry. They're not like sullen and losing interest because they'll play video games for 8 hours all day and they always have liked that, so they haven't lost interest in that. You know, so the checklist can be misleading. ADHD. ADHD kids not only have a difficult time attending academically, but because they're inattentive socially as well. They don't pick up on social cues, because how do we learn social cues? By just watching and observing. Like how often were you purposely taught, hey, let me teach you that when you really want to get her attention, I'm going to hold her hand and walk you through it. We're going to walk up to her, appropriate distance, respecting boundaries and bubbles, right? And say, hey, I'm Carrie. I was wondering if you wanted to play with me. How often are we really that intentional with an 8-year-old boy to walk him through that process and get him comfortable and confident? And if he's not comfortable and confident, et cetera, et cetera. So ADHD kids are socially and emotionally delayed because they're not picking up on all those social cues that are happening around them. So they're acting more like 3 and 4 and 5-year-olds, even though they're 8, 9, and 10. So they're missing out on all of that because of their inattentiveness. There could be a spectrum. We could be dealing with something on the autism spectrum. And that's just a really big, huge, giant umbrella that I'll get into here in a little bit too. And then of course there's this, and I'm not a fan of this diagnosis. I'm going to talk about it a little bit. So the struggle with children, and this is 18 on down. I mean, this could even be adults. But when I'm talking about little people all the way through adolescence, you think you know, but you don't. You don't know. I've seen clients for 6 months, and we're still turning over puzzle pieces. And we're still turning over puzzle pieces. And more information shows up 3 months down the road, and oh, that puzzle piece makes sense. Good thing that one got turned over. That's helping the picture. You don't know. You don't really ever know. You make assumptions and you try to understand and you try to know, but there's always more information coming. Kids' challenging behavior or signs and symptoms of mental health is complicated. It's very complicated, and it could be any of these things. So trauma trumps everything. That's the #1 rule when you're raising children, when you have little people, when you have adolescents. Trauma trumps everything. So if you have a child who has experienced trauma and that child has a diagnosis of ADHD, ODD, I emphatically will tell you that that is a wrong diagnosis, that that child probably has a trauma diagnosis that looks like ADHD and ODD. Trauma trumps everything. It's the first thing that you need to assess for every time. It's also difficult to uncover because oftentimes people don't recognize what is traumatic. And we forget that trauma can happen pre-verbally, which messes with the wiring in your brain. So there's this thing called ACEs. ACEs too high, Adverse Childhood Experiences. It's 10 questions, that's all it is. It's the most ginormous study ever done of this magnitude on this kind of a topic. So you can just Google ACEs, A-C-E-S, ACEs too high, and you come up with this amazing website with all this great information. I jumped to myth number 3. When I say trauma trumps everything, myth number 3, kids are resilient. Nope, not so much. They're not. They're not resilient the way you think they are. Children are not innately resilient to severe and chronic trauma. Children, birth to 3, are the most sensitive to trauma because they do not have the capacity to process it, have language associated with it, make sense of it. It only strictly impacts how their brain wires. So it literally is wiring their brain based on the trauma they're exposed to birth to 3. Now, a singular car accident, no, that's not, oh no, my kid was, no, we're talking about like something severe. It's a severe and chronic trauma. And when we're talking about the problem that it is, we're talking about things like, hey, the bulk of our chronic diseases, diabetes, heart disease, cancer, autoimmune diseases, as well as the mental health things like suicide, depression, violence, it's because kids have ACEs scores that are too high. If you go and take an ACEs checklist out of these 10 questions, ACEs scores of 4 or higher put you at serious risk of all of these physical and mental health challenges. So if you go through the ACEs score and you're like, dude, mine's a 5, that's okay. Awareness is power. It's good that you know that. Or if you do it for your kid, oh my God, my kid's ACEs score is a 4. Okay, that's good to know. Don't freak, don't panic. Good information, because that impacts what we're looking at in the big picture. So here it says an ACE of 3 or 4 puts him or her at risk of chronic illness, et cetera, et cetera. We've got all these statistics that tell us all the stuff associated with it, but I want to fall here where it says, what's the link between abuse and chronic disease? Damaged brains. You can find tons of information, Harvard Center on the Developing Child. There is no doubt that the toxic stress, that's toxic stress. That's not even like trauma. Witnessing domestic violence is toxic stress. A parent who is using substances in the home is toxic stress. Severe neglect, emotional abuse, that's toxic stress. And chronic childhood trauma stunts the growth or fries the circuits of children's brains. Oh, good information. So when you have an 8-year-old that looks like he's ADHD and ODD, but that child has a history of trauma, it's not ADHD and ODD. Okay, so trauma trumps everything. Second, there is a thing known as neurobiological disorders. Those are biological brain disorders that interfere with normal brain chemistry. ADHD, not your choice. Wiring in the brain's a little bit different, neurotransmitters firing different, a little bit too much of this, a little bit not enough of that. It is what it is. It just is what it is. Same thing with anxiety, same thing with depression. It's not like, hey, just get happy, snap out of it, stop self-harming. Hey, that flyer out there on that table, the one on self-harming, phenomenal resource. If you have that in your life at all, that was an excellent, whoever wrote that, spot on, it was beautiful. Children often have multiple conditions because they're complicated little people and they change and they're growing, right? And they're changing and they're growing and they're changing and they're growing. So they're really complicated. And so one day you think you have it together and then all of a sudden the next day it changes and you're like, where did I just, all of a sudden we were dealing with this. So we can have multiple co-occurring conditions going on and it's hard to kind of weed them all apart. Each disorder manifests with overlapping symptoms, which is kind of why I said that, like challenging behavior up here and all these other things below the line. These disorders can manifest with overlapping symptoms of various presentations and severity. You might look one way with your social anxiety, whereas you might look a different way with your social anxiety, and you might look something different with your social anxiety. Awesome. So we have to kind of be aware that it's going to look different for different kids. Here is an example of what we're looking at here in terms of like symptoms. We have this childhood and adolescent depression bubble. But then when we're looking at all of these different disorders and how they can be overlapping in their symptoms and how they could be technically co-occurring, not a blood test. Could you meet diagnostic criteria for an anxiety disorder? And could you meet a diagnostic criteria for ADHD? And could you meet diagnostic criteria for depression? Yep, you could. Now, best practice, if we're talking clinically, is not to overload diagnoses. This is another one of my high horses. I don't like it when people come out of a doctor's office with 5 diagnoses. Oh, I've been diagnosed with generalized anxiety and PTSD and OCD and some, I'm like, no, just no. Like, we don't need to have the entire alphabet soup on this piece of paper. It's not a batch of, it's not, hey, let's diagnose you with everything you technically can have diagnosed. It's a clinical assessment, and it takes some talent to do well, and then you pick the one that's at the root of it all. You don't pick all of them. So if you went to a doctor and your kid came out with 3 diagnoses, I'd pause. I'm going to pause a minute. I'm not sure that I need my 8-year-old with 3 diagnoses. Let's go to probably the foundational one that's maybe at the root of it all, because the other ones are all overlapping symptoms that we're seeing out of one thing. You really have to know your kid, and you have to really be an advocate for your kid and follow your gut as a parent or as a professional where you kind of know that kid best, and so you're really searching for what they need. Anxiety is real in children. I've seen selective mutism in kiddos as young as 3. It's where they really want to talk in social settings, but they can't, they truly can't, but they really want to, hence the anxiety. So oftentimes in social settings, they end up in tears because they really wish they could talk, but the anxiety's getting in the way. That's in little tiny 3-year-olds, that's babies. We can definitely have separation anxiety in little people. We can absolutely have obsessive compulsive disorder in kids pretty young, shockingly young, which sometimes overlaps and looks like autism. So sometimes it can be pretty confusing. And then just a generalizing, I've seen it all in one degree or another in kids of any age range. So we don't want to just dismiss the extra tears or the extra, they're acting like they're, oh my God, I can't believe, and they're kind of freaking out, or they're saying a bunch of words to you, and they're crying, and they're holding themselves, and you're like, dude, relax. And that's kind of the thing that comes to mind is you're like, seriously, take it down a notch. It could be a true anxiety-based reaction in which they definitely want to take it down a notch. They would love to take it down a notch. They just need help understanding and learning how to take it down a notch. ADHD here is also highly comorbid is the word. I mean, there's a lot of co-occurring diagnoses, so you oftentimes have ADHD, ODD matched together. I'm not a fan of that at all, but I had mentioned here, ADHD is the technical diagnosis that we find in the new DSM manual. So truly, if it's a brand new diagnosis, the diagnosis is going to read ADHD, but it can present with or without the hyperactivity. Kids without the hyperactivity, where it's truly just an inattentiveness, where they gaze out the window, they kind of go into their own head, they have a really hard time attending. That's the harder kid to diagnose, because the ADHD is super easy to diagnose, right? We're like, dude, they're hopping over the, they're bouncing off the walls. It's like a little gnat on crack. We can never have them sit down. Like, it's so obvious. They present very differently, but we can have a child or an adult with a attention deficit disorder, but not the hyperactive piece. Very interesting to really read from an adult's perspective of what they wish people knew about children with ADHD. That's the most insightful. If you can have an adult who is an ADHD child who either wrote a book or submitted something on YouTube or wrote an article or could talk to you, it's brilliant to have them explain it from their own voice and their own lens, because then you're like, oh. So my understanding oftentimes is I don't have the capacity to filter all the sensory information coming at me. And so like right now, there's a lot of sensory things coming at me. There's some cars driving by. There's maybe some noise from some different fans. There's obviously like the echo of the microphone. I'm watching a lot of different things happening. And people with an inattention, like a difficulty with attending, they don't have the filter to stop all of that and put it into its buckets and only focus on what I need to, like selective attention. So they're always overwhelmed with all of it. And so just focusing on the one thing is painful and hard. But we also have a lot of co-occurring issues going on with ADHD. Obviously learning disorder, because we really have a hard time focusing on the information coming in from a cognitive capacity, but from a social capacity as well. So I'm very socially emotionally delayed. I could be 12 and act more like 6. Definitely have increased injuries for obvious reasons. We just have a harder time problem solving and doing that forward thinking. Behavior problems, absolutely. And then that's gonna probably lead to some anxiety and depression, because I'm kind of a miserable 8-year-old, honestly. I wish I could be happy. I wanna be happy, but this kind of sucks. And so right now I'm really struggling with bouncing all of this around, and my parents are always mad at me and nobody wants to play with me and teachers are always yelling at me. I mean, this is a really difficult diagnosis for somebody to like live with. Research, hands down, we have it over and over and over again, so there's no disputing it. Research proves that behavioral therapy first, then meds. They work well together. I definitely advise you working with both of them together. I think it is appropriate and necessary. I wouldn't keep a kid with asthma from his inhaler. I wouldn't keep a diabetic from his insulin. I wouldn't keep an ADHD kid from his meds. I don't think that's nice. But it's not your only answer, and it's not the one that you should just automatically be throwing at anybody and thinking it's gonna fix something, because it's not. Just because the meds help, it doesn't mean they fix it, and they don't help the child with all of these other skills that they need to acquire. But interestingly enough, research time and time again says that you should engage in behavioral therapy first before you add the medication, which is very interesting. You would think it's the other way around, but it's not. Autism spectrum disorder has changed. It's now just called ASD, autism spectrum disorder. There's no Asperger's anymore. The greater powers that be that wrote the new manual for the clinical blah-de-blah decided that they didn't want it in there anymore. So if you have somebody who's diagnosed with Asperger's 5 years ago, that doesn't exist anymore, whatever. So now it's under this big umbrella of autism spectrum disorders. It's a ginormous umbrella term that encapsulates or embraces a wide range of symptom, skills, and ability levels. We can have mild, and we can have moderate, and we can have severe. It is a neurobiological based condition. Kiddos who have ASD just operate in the world differently than us, period. They just do. Not their fault, not their choice. They see the world differently, hands down, period. And here is a giant visual on what we're looking at when we see ASD and how unbelievably complicated it can become. Like I said, my husband and I are foster parents, and right now we have a 3-year-old with autism in our house. And he's just the sweetest, most amazing little person ever to walk the planet. He's the most autistic kid I've ever worked with in my career. So that should tell you something, right? And he fits about 90% of these bubbles. I'm like, oh my gosh, he's like that whole chart. They're absolute social deficits because they operate in the world. They look at us differently. You are different to an autistic kid than a non-autistic kid. Relationships are different. Social connections are different. It is what it is. Language impairment, absolutely. Repetitive behaviors, they become engaged in similar things and they kind of like to engage in that. I don't mean like stereotypic, like they're always rocking or they're always flapping. I just mean like they're always engaged in the same kind of, like I'm going to do these magnet tiles over and over and over again and continue to build this same design for a while until I, have worked my way through that one. But then we have all of this over here. We have these associated systemic issues like GI disorders and immune dysfunction. We have these associated neurological issues, sleep deficits. This little guy will be chatting away to himself at 11 o'clock at night. I'm like, dude, why are you still awake? And why are you talking to yourself at 11 o'clock at night? Like, go to bed. He's just chatting away to himself in his own little language because he doesn't really have language yet, hence the language impairment. But so there are sleep deficits and sleep disorders associated. There's mood and anxiety. We have anxiety disorders. Oftentimes we see things like OCD or obsessive compulsive disorder. We could have some hyperactivity, which is looking at this attention piece and this ADHD piece. It's a big, giant, overwhelming, interconnected world. So being very thoughtful of that. Now, I will, just for the sake of whatever, I put OCD on here. I have a hard time with this diagnosis, a very hard time with it. It is called oppositional defiant disorder, and it is characterized by children who have a lot of anger. They will intentionally pick fights. They will intentionally go to battle with adults. They are very, very sensitive to the power distortion between them and a grown-up. That is where this OCD foundationally comes from. Is there is a problem. I have a fundamental problem that you have more power than I do. So therefore, I willingly am going to do battle with you, and I will always engage in an argument with you, because as soon as you argue back, we're equals. So I will engage in a verbal debate with you, and you will attempt to engage in a verbal like, hey now, we're not going to argue about this, what I said happens. And then they come back at you, and then you might say, hey, you know what, I already gave my answer once. I said we weren't going to do this, and then they come back at you, and then you say, okay, you know what, I've said it 3 times. We go over this every single day. I said that this wasn't going to happen today. And they're like, well, yeah, but da-da-da. And you're like, yeah, but not yesterday. Yesterday, we're not talking about yesterday. Today, we're talking about today. And the kid, and 5 minutes later, you're angry, right? And you're up here because now you've engaged in this 5-minute long conversation where you started calm and quiet. You're like, yeah, dude, we're not going to do this again. Yep, nope, I gave you my answer, all is well. But you just participated in a 5-minute argument with a kid who loved every second of it. Because arguing with an adult for a kid with ODD is winning. Consequences are irrelevant. The argument was the payoff. And the minute you engage in a verbal disagreement, he levels the playing field, you are equals, he won. It doesn't matter that you took his phone. It doesn't matter that you took away privileges for the rest of the night. It doesn't matter that he doesn't get to go to the birthday party that weekend. Irrelevant. Just engaged in a 5-minute argument with an adult, and we were all of a sudden equals for those 5 minutes. Thank you very much. So very angry, use inappropriate language. They want the shock. They want the upset. To see you upset is a good thing for them. They like to see you flustered and angry. Frequent outbursts, because as soon as I'm really getting to the point where I'm going to lose it as the kid, then I'm going to lose it. There's no remorse. I'm doing it intentionally and on purpose because it feels good and I like it. Relationships suffer, obviously. Relationship with parents suffer, very hostile towards their peers, or could actually be well liked by their peers. They could be seen as kind of cool kids because they're the kid that's going to go do battle with the adult. And sometimes kids kind of like that. They're like, dude, I kind of like Austin. He's badass, you know what I mean? Because he's the kid who's going to go, toe-to-toe with the whatever. Poor response to authority, that's a no-brainer, that goes in the whole shebang. Seeks out verbal confrontation, blows small arguments out of proportion, and will not take responsibility for their actions. Absolutely not, ever, ever, ever sorry, not ever gonna own it, not my fault, ever, ever, ever. Now, what's interesting is I struggle with this because if it's me in my world, I back up and I end up either seeing some level of insecure attachment or trauma in the majority of the history of these kiddos. And when I'm dealing with an insecure attachment or some kind of a history of neglect or trauma, it might look like this by the time they get to middle school or even elementary school or high school, but I probably could have dug back to find something different down there. Maybe. Not every time, it's never every time. And I don't want to slap that on, every kid I've ever met. Grandma and Grandpa were raising a little guy. He was 5. They got him when he was about 2, 3. He had a little brother who was a couple years younger. Mom and dad, bio grandparents through mom ended up adopting both of them because their daughter was involved in substances and was not able to care for her children, so they ended up making their way to Grandma and Grandpa. And Grandma and Grandpa said that the 5-year-old that they've had since he was about 2 or 3, when they took him to a psychiatrist, the psychiatrist at the age of 2 or 3 said, "Wow, this is the most ODD kid I've ever met." Okay, nice job, psychiatrist. Maybe you should have looked at the kid's history. His mom was a substance user, and he spent the first couple years of his life living with somebody who was addicted. Maybe that had some play in this whole thing. Like, how dare us at the age of 3 just jump to, this is the most ODD kid I've ever met. Really? Maybe we should look at the whole picture here, not just what's presenting in your office in those 15 minutes. But again, I've also met kiddos who are adolescents who really, I couldn't find something maybe back there. And why is a kid ODD? I don't know. I wish we did. You can research it all you want. I don't know where the answers lie. But at Boys Town, this is what's super interesting, is at Boys Town, when I lived there, so Kirk and I lived there as family teachers, and we had 8 teenage boys living with us in our home, and family teachers are taught how to interact with kids, to de-escalate and stay neutral, and a lot of social skill teaching and a lot of relationship building. School, we have our own school, so the teachers are all taught the same thing. Here's how you interact with kids, here's how you build relationships, here's a little social skill instruction. And then you've got coaches, taught the same way. Here's all the coaches running the sports teams, interacting with the kids in the same way, building relationships, understanding all of it, yada, yada, yada. I never, ever, 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 ever met a really off-the-charts ODD kid at Boys Town. And here's why. Because we don't argue with kids at Boys Town. Like, we have a model. Like, we have a really specific model. We just don't engage. We're very neutral, and we have a process. We have a really systematic process. I haven't been there for about 10 years, so I can't speak to how it is now. But I'm like, dude, I never really saw ODD at Boys Town. That's really weird, because they weren't ever getting the payoff. Principal wasn't doing it, teacher wasn't doing it, coach wasn't doing it, family teachers weren't doing it. So interesting that it was that behavioral that we could shape it to that degree. I didn't really recognize that until I had left. And then I worked with some ODD kids in like a public school setting where there was arguing with mom and dad, and there was maybe some arguing with some teachers or some administrators. So they're getting intermittent reinforcement, because even if it's only like once a day or twice a week, it's still reinforcement. Whereas kiddos in a confined kind of environment like that weren't getting it. Okay, next steps. If you are concerned and you have a child with a diagnosis, or you're concerned that you might have a child with a diagnosis, yes, ma'am?
I did this.
Yes, okay, yes, yeah. So the question was, do behavior charts work, in a nutshell? Do behavior charts work? Token economy, right? I'm an attachment behaviorist. I mean, like, I'm trained in parent-child interaction therapy. It's a very behavioral-based. It's also the most widely researched, evidence-based practice that we have for kids 2 to 7 who have defiant disorders, like defiant behaviors. It's very behavior-based, very systematic, but it's heavily, 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 heavily relationship-based. At the foundation, you have to graduate level 1 before you go to level 2 in PCIT. Level 1 is all about relationships, nothing about correction at all. Boys Town, same way. Now, interestingly enough, we had a 7-to-1 ratio for a daily kid. I'm going to get to your long answer to your short question. So I get a kid who moves into my home from literally Kareem, and he would be so happy that I used his name. He would have no shame whatsoever. He's awesome. He's in his 30s now. My boys are now in their 30s. Kareem moved in with us from Rikers Island in New York. So here's this 16, 17-year-old kid from New York who moves in with like me and my husband. You know what I mean? Like everyday, normal, white Nebraska people. Hey, Kareem, how's it going? 7-to-1 ratio, which means, so it's all social skill instruction. So when I'm meeting Kareem, my tolerances are in the dirt, my expectations are through the roof, but we're social skill teaching on everything that we do. Kareem, as a daily kid, had a 7-to-1 ratio, which means I had to have a positive interaction with Kareem. There had to be 7 of them for every 1 corrective interaction I had with Kareem. So if Kareem did something like I said, dude, your turn to unload the dishwasher, and he's like, oh my God, this is so stupid. I might have a negative interaction. I might say, hey, you know what, Kareem, just now I gave you instruction, and you complained and rolled your eyes, so get out your point card, negative, blah, blah, blah. He's gonna earn some negative 2,000 points, not follow the directions, argue, complain. That was 1 negative teaching interaction, and it was initialed on his card. I had to have 7 positive teaching interactions with him for every 1 negative teaching interaction with him. Now, not instantaneously, but over the course of the big picture, right? He was a daily kid. So then it would be like, dude, great job following instructions. You just said, okay, I appreciate that. Kareem, thanks for staying on task so well with the dishwasher. Go ahead and grab it. Hey, Kareem, I like the way you offered help to Ryan. Let's get that on your point card. Hey, Kareem, I appreciate that you put your book bag away. Personal responsibility, get that on your card. Hey, Kareem. 7 times to every 1 negative teaching interaction. So then we would have a point card review, right? So we gather up all these point cards. My boss would come in and grab all of Kareem's point cards, and Monday through Sunday, 7 days, he would look at all of my initials and all of Kareem's negative teaching interactions and positive. He would add them all up. Let's pretend I had 4 negative interactions with Kareem every day, which is not a big deal. Think about parenting your children. Think about the kids in your classroom. How many times do you have a negative interaction with them where you have to give them correction? Put your shoes away, pick up your backpack, load your dishwasher. Are you done with your homework yet? It's past your bedtime. Are you serious? You're still taking this long? Did you brush your teeth? I mean, like, good Lord, how many just rattle off? 6, 8? Let's pretend I had 4 negative interactions with Kareem a day. What's 4 times 7? Quick, somebody, math, 28. I'm a therapist, not a mathematician. 28, which means at the end of the week, if I had to have 7 times that of positive interactions with Kareem on his point cards, what's 28 times 7? Quick, math. 40, 50, 60, 70, 80, 9, almost 200. I had to have 200 positive interactions with that kid to offset the 28 negative teaching interactions I had with that kid over the course of 7 days. Do token economies work? Yes, if relationship is there. Period. Period. Consequences do not work outside the context of a relationship. That's why we don't graduate kids in PCIT. It's parent-child interaction therapy. Parents don't get to go to phase 2 of PCIT until you graduate phase 1. Phase 1, relationship. Phase 1, no correction at all of any kind. Because we're healing the relationship. We're setting that on the right path before we get to the place of correction. So yeah, token economies work if they're set up well and right. A lot of us don't use them well or right. So for evaluation, oh my Lord, ask a lot of questions. Please ask your pediatrician questions, ask your teacher's questions, ask your therapist questions, ask your psychologist questions. Read the internet, get to know, find a professional who specializes in the whole child, birth to whatever. Psychologists are not innately trained in early childhood mental health. They're just not. They might have had 12 years of college and they really know 12 on up. I'm really sorry, but they do. They know 12 on up. But they don't necessarily have advanced training in trauma. They don't have advanced training in infant mental health. They don't have advanced training in attachment. They don't have any of that in their college prep. None. So you have to find somebody who gets it, who really gets little people, brain, in utero, development, all the way through in order to get you the right help that you need or want. And be willing to have everything considered. If you really want to help your kid, be open to having all of it considered and looked at, because really that's the help that you and he or she want. Then educate yourself. Find out as much as you can about your kid's diagnosis. I mean, literally, like if I had diabetes, I would learn everything I know about diabetes. My nephew was recently diagnosed with Ewing sarcoma, bone cancer. What did my brother and sister-in-law and me do? Research the crap out of it. You want to know everything you possibly can when your kid has something. It doesn't, anxiety, depression, self-harming, all of that stuff. Learn everything you can about it. And work with everyone to create a team approach. Which means if my kid spends 40 hours a week in this building, then I'm going to have to partner with some people in this building because they've got eyes on the kid in a way that I don't. And they know more about my kid probably than I do because they see him outside with friends or her outside with friends. So I need to be okay partnering. Not working against the school because they're horrible, terrible people, but partnering with them in order to find partners that I can connect with. If you do want counseling, it absolutely 100% should include psychoeducation for everybody. Your counselor should educate you and your kid on what his or her diagnosis is and why. Age appropriate, of course. Don't be left out of the loop. Don't drop your kid off at counseling and go once a week. Hey, I've been taking my 12-year-old to counseling once a week all year. What's your kid's diagnosis? I don't know, maybe depression? Are you ever included? No, never. What? Why would you do that? So make sure that it includes psychoeducation for the whole shebang of you. Include a treatment plan and goals. You should see it. You should sign it. Your kid should not be going to counseling without you having some kind of awareness of a treatment plan or what's happening. Now, I know there's a lot of confidentiality, and I was super protective of my kids, like really protective of my kid clients. And I told them, anything you say in here stays here. Just because you're only 12 doesn't mean I'm hauling in mom and dad and divulging everything you've ever said. Not going to happen. You're my client, which means I will honor your confidentiality. But your therapist's goal is to help you and your kid connect, not to be a replacement to you. So your kid's therapist should be doing everything to be that bridge, not that replacement. So it should include parental involvement. Hey, thanks for telling me all this. What do you think is the path that's going to get us from here to letting mom and dad know about it? How long do you think it'll take? Never. Pick a number. Any number. 56. Great, 56 sessions. All right. We'll start with that as a goal. You always have a goal of connecting family. And then if you have little people, child-parent psychotherapy and parent-child interaction therapy are our 7 on under treatments. And those require parental attendance and participation. You can't see a kid without an adult. So if you're looking at treatment for littles, you have to be there because it's really about the relationship and healing that. Medication might be necessary. I'm perfectly fine with it when it's appropriate. ADHD, depression, anxiety, meds can be incredibly helpful. I wouldn't ever keep them from anybody who needed them, but ensure the diagnosis is accurate and invest in counseling first before you jump to meds. It's more expensive and it's more time intensive and it's more difficult and it's more intrusive and it's harder, but it's better. Okay, what time is it? I talk nonstop for a straight hour. It's 7:41. I literally talk nonstop for about a straight hour. Thanks, let me back up. So let me see how solid I am on memory. The ACEs scores include obvious ones: physical abuse, sexual abuse. That's a no-brainer, right? And then we look at things like emotional neglect. I would just neglect in general, like parenting neglect, not just emotional neglect. I know that 5 of them had to do with the no-brainers. The other 5 were interesting because the other 5 addressed things like witness to domestic violence, like did you lose a parent due to divorce or death? Did you ever see your mom harmed by your dad? Let me jump up here. So it says, yes, okay, here it is. Where's my little clicker? I have no idea where I put my clicker down. Oh, with the little red laser button. So it says, so here we have the physical abuse, the sexual abuse, the verbal abuse. I left that one off. And then we have emotional neglect and physical neglect. And then 5 types of household dysfunction. So if a parent has a mental illness or a drug addiction, that's an ACEs score or an ACEs check. If you have a family member in jail, if you have a mom who is a victim of domestic violence or if you've lost a parent through divorce or abandonment. That's all they have on there, just those 10 indicators. Pretty simplistic. People have asked a lot of questions about what about this and what about that? How come this one isn't on there? How come that one isn't on there? Interestingly enough, this was just the simplicity of the study. It was these 10 indicators. And again, it has been the most widely nationally studied, I don't even know how I should say that, results where we are finding that if you have 3 or 4 yeses to any of those 10, you are at an increased risk for health and mental health diagnoses. I would say for trauma, I have a 2 and a 3-year-old in my home right now for foster care, and their parents were substance users. So obviously right there, we've got some kind of neglect, right? Substance use of both parents, these little 2 and 3-year-old kids. Removal from a home is not an ACE score, but in my mental health world, that's traumatizing. When you take 2 and 3-year-old little people out of their home and put them with strangers, that's traumatizing. I've had to use respite a couple times for my little people because of just, right now I literally have 8 kids in my house. I have my 3 bios and 5 fosters. I'm running a small group home at my house. And so we've just had some things where we've necessitated some kids having to have respite. And I honestly think that is traumatizing. I hate it. I absolutely hate putting that 2 and 3-year-old in respite care with other lovely, amazing, kind, beautiful human beings who treat them safely and warmly and lovely. But it's another displacement yet again. And so we're just racking up these scores. Substance use in the home. Violent movies, the older kiddos I have in my home are 11 and 13. They've been displaced multiple times. This is not their first removal. And they have divulged that when they were little, their parents really liked scary movies or horror movies. And so they've always watched them as a family. And so the little ones, when they were younger, the boy would say, I always, they were always really scary to me. I would always end up with nightmares. I didn't want to watch them. Yeah, but I've gotten over it. And there's like a in my stomach that just kind of makes me cringe a little bit because I'm like, oh, that's not appropriate. Like his little brain wasn't prepared to handle all of that information at that age and process it. And so when we talk about trauma, it's interesting when we say put yourselves in in a 2-year-old's shoes. What is considered traumatizing? Multiple relationships where they are, we're in a relationship, we're not, like in terms of a mom or a dad being introduced and removed. Those weaken, it's kind of like a Band-Aid. Think of it like that. I stick a Band-Aid on and the first time it sticks really, really well and then I take it off, but I keep using the same Band-Aid, so I put it on again and then it doesn't stick quite as well, so I take it off and then I put it on again, then I put it on again, and pretty soon after 4 or 5 times, there's no stick to the Band-Aid. It's relationships. So we have a lot of different things that factor into what would be considered traumatizing to little brains that are being developed, but those are the 10 ACEs score items that are identified. I had a mom one time who admitted that her husband came back from deployment and had some PTSD himself, of course, and really was struggling with his anger and his emotions. And when I said, has he ever hurt you or the kids? She said, no, he's never hurt me, he's never hurt the kids. But then a story down the line divulges that he did get so angry one time that he punched the wall right next to her head. So she's standing there, and he did put a fist through the wall right next to her. The 3-year-old was holding onto her leg. But mom said, he's never hurt me or the kids. So it's what we perceive or what we see or what we think we see and perceive. Yeah, that hurt the kid. That hurt the 3-year-old. That was terrifying, and that 3-year-old didn't have the language or capacity to process that at all. So, any other questions? Yes. Reframe it. How would you share some of this information to a high school audience? How would you share some of this information to a middle school audience? Or how would you work with those kids who might be in these shoes? Perfect. Okay. So no, I would, and you said you have familiarity with PCIT, but now working into these older ages is a newer realm. Okay. So, you're right, it is a broad answer in terms of if you are parenting middle school kids in your home now. So I look at the kids in my house now and I'm like, okay, they're 11, 12, 13. I've got a gaggle of them right now at that age range, and that's all middle school. So the older sister, the 13-year-old sister, has gone through all of this. Do you know what I mean? Like, she's living this. She's in foster care right now for the second or third time in her life, and she's got these little brothers. And so my children are learning through our conversations, that experience of how you're, I mean, some of this information, yeah, I'm pretty honest. I'm pretty honest with kids. Not in a scary, oh no, your life is awful kind of a way, but in a, hey, you know what? Our brains do develop in the first 3 years of life, and we do set the foundation. And that's not like, oh no, now I can't fix it. That's just recognizing, here's where I'm starting. Here's my starting line. And you know what? I'll call her Carrie. I'll pretend like her name is Carrie. And say, hey, you know what, Carrie? You've had some different things bring you up to this starting place, and that's just your reality. That's not bad, that's not good, it just is. I mean, this is the stuff you're bringing to the starting place. But when we're moving forward, we're looking at how my friends are interacting in the world and what choices I'm making, I have to start kind of being aware of why I'm making the choices I'm making. And having an awareness to say, it really wasn't appropriate for you to watch those super scary movies when you were little, and it was really sad that maybe you had to see mom and dad using. And maybe some other things. I'm assuming there were some other things that she witnessed. I would assume there was some domestic violence happening in the home. And so I would say things like, hey, you know what? I know that your eyes have seen a lot, and I know that you are very familiar with the world. And then here's the big, huge but. But that's unfortunate that that's all the stuff that's going on in your brain and filtering how you see the world. But you can still, that's just an understanding. I'm huge on psychoeducation for kids. If I have an 8-year-old and I want to explain to him what ADHD is, or if I've got a 12-year-old and I'm trying to explain what depression is, or I've got a 16, 18-year-old and I'm trying to explain anxiety, huge on psychoeducation. They need to get them. It's kind of like sex ed. We need to teach middle school kids all about all of that stuff because it's their body. They need to know it. All about helping them understand this. There are some amazing videos, some really great itty-bitty tiny clip videos. If you go to Harvard Center on the Developing Child, they're like 2 minutes or less. And those are really written for adults, but if you start kind of sifting through some of them, that gives that picture of, oh, okay. And not to be scary, but it's you. It's your brain, it's your body, it's you. You have every right to have an understanding and awareness of how you got to this place. Yeah, I'm pretty real with kids.
Weaning them off, or, I mean, what's your thoughts on that progression?
Absolutely realistically doable. I think people in general with adult ADHD can have to be on some kind of supportive medication throughout their entire lives, and there's no shame in that. Very common, depending on the severity and the social supports and the temperament and wiring of the child. Very common for kids to outgrow the need because they increase their own behavioral strategies. And so no, very common for kids to learn those increased coping skills as their brain continues to develop. Your brain is not done until mid-20s. Frontal lobe, all that executive functioning, all that ability to problem solve and withstand, delayed gratification and decision making, all of that stuff that happens in that frontal lobe. Now, the newest research says give or take 25. And so common that maybe we're just waiting for all of those different parts of the brain to develop more fully until they have all the skills that they need. But yeah, I'm okay either way. I think it's just very dependent on the person and then the supports that they have around them, in terms of learning those skills. Harvard Center on the Developing Child. Yeah, in YouTube, if you go to YouTube and Google, or like YouTube search, Harvard Center on the Developing Child, they have 3 of them. And they're literally less than 2 minutes apiece, so you could watch them all in under 6 minutes. But they're really well done. They're great for parents. They're a great introduction to just seeing it in a very simplistic, brief kind of, they do in 6 minutes what I took 90 to do. And then if there's any, like I said, my information is on that card. If for whatever reason you have a question that pops up later, or there's something else I can do to help or get you connected with, there's this great resource that nobody ever knows about. We need to do a better job of publicizing it. It's at the weirdest site. It's at the the Center for Research on Vulnerable Young Children. It's got a very long name. It's housed out of the university. The website is actually nebraskababies.com or .org, so you would never think, right? Well, they have an approved provider list of everybody in the state who has gone through what they have been able to verify as trauma-informed clinical interventions like CPP and PCIT and TFCBT and all of like EMDR and all those good ones. They've got a list, like a statewide list. You're like, dude, that's genius. Why don't we all know about that? So if you're looking for just kind of things like, hey, I'm really looking for a provider and you need more resources to be able to get connected with families, feel free to let me know. Maybe I'll just throw that up on my Facebook page and try and get it out there to say, hey, this is there. And the department does a great job of updating it almost monthly. They try and stay on top of it, so they do a nice job of attempting to keep it relevant. Okay, thanks for coming.